Bismillah ar-Rahman ar-Rahim. Dear students, fifth year medical students, we will talk today about the neuromuscular disorder. The neuromuscular disorder are diseases of the motor unit, and they are common in children. May be congenital, may be acquired, chronic or acute, or progressive or static, and it may or may not be genetically determined. So laboratory confirmation, it is important. Why? Because there is overlapping clinical manifestation. All of these patients, they have weakness, and the weakness may be due to direct pathology involving the involuntary muscle, the voluntary like skeletal muscle, or maybe the indirect pathology that arises from the nerve or the neuromuscular junction causes weakness in the muscles. So the site of injury located in the motor unit, and maybe as anatomical site may be located in the dorsal ganglia root, or it may arise from the motor neuron or peripheral neuron or neuromuscular junction or the muscle or any combination of these sites. So when it arises from the dorsal root ganglia, as in Friedreich's ataxia or herpes, in the motor neuron we have two varieties. Are there those arises from the ventral horn cell, as in spinal cord, like poliomyelitis, spinal muscular dystrophy, amyotrophic lateral sclerosis, as seen in adults, and in the peripheral neurons, either in the axon or in the Schwann cell. In the axon pathology, usually there is axonal peripheral neuropathy. In the Schwann cell pathology, as in chronic inflammatory demyelinating polyradicular neuropathy, maybe involving the neuromuscular junction, as in myasthenia gravis, or in the muscle, as inflammatory myopathy or muscular dystrophy, or any combination of these. Sometimes there are associated CNS finding. So here we have the site. This is anatomical structure. We have the diseases that originate from the dorsal root ganglia. Here we have the herpes zoster and Friedreich ataxia, or diseases arising from the motor neuron in the ventral horn cell of the gray matter and the spinal cord, and this is involving the spinal muscular dystrophy, amyotrophic lateral sclerosis, poliomyelitis, or it may arise from the ventral root and the dorsal root, and here we have the Guillain-Barré disease, or it may arise from the peripheral nerve when the dorsal and the ventral root join together. We will call it here the peripheral nerve, as in a polyneuropathy, entrapment or compression neuropathy, and trauma. And we have the disease of the muscle. There is muscular dystrophy, myotonic dystrophy, myotonias, and myositis. And lastly, as the disease affects the neuromuscular junction, as in myasthenia gravis and Lambert-Eaton syndrome and botulism. The Lou Gehrig's disease is other name for amyotrophic lateral sclerosis, and they called by this name because of this a baseball player. He got the disease, amyotrophic lateral sclerosis, and he was the victim of this disease. Another two famous with the disease, famous people like Stephen Hawking and this TV show star, her name Mary Pinto. These are another two victims of this disease, but fortunately here it is disease of adult and not young, of pediatric age group. So what are the clinical manifestation? During examination of the neuromuscular system, we have to assess the muscle bulk, whether it is thin or good muscle, good bulk, and the tone and strength. And regarding tone and strength, first we should not confuse from passive tone and the active tone. Passive tone is that the range of motion around the joint. This is what we call the passive joint. While passive tone is a range of motion, while the active tone is a physiological resistance to movement. So when we move the limb, there is resistance. This is the strength of the muscle. And we have to know that other points, which is important to know, that head lag, when we pulled the infant from supine position to a sitting position, there is head lag sometimes, which is a sign of weakness. It is not of hypotonia, it is weakness. And hypotonia, sometimes we have to remember that it is sometimes associated with a normal strength or with weakness, so it may be present with normal strength. Enlarged liver may indicate weakness, and sometimes enlarged muscles may indicate weakness or may be strong. And thin waisted muscles may be weak or may have normal strength, which is unexpected for a thin waisted muscle. So the distribution of this component is important. We have to remember that generally myopathies, they follow a proximal distribution of weakness, and there is muscle wasting, with the exception of the myotonic muscular dystrophy. The muscle here, it is hypertrophied. And in the neuropathy, generally the weakness is distal in distribution, with the exception of juvenile spinal muscular dystrophy. Sometimes there is involvement of the face, tongue, palate, and the extraocular muscles. This is important clue for the differential diagnosis. Now, regarding tendon reflexes, generally in neuropathy they are lost, and in the motor neuron disease they are lost, while they are diminished but preserved in myopathies. And now we have a few specific clinical features. They are important for the diagnosis. First of all, fasciculation of the muscle. What do you mean by fasciculation? There is a twitching or some sort of motion, abnormal motion or movement of the myofibers, maybe involving a bundle of fibers or a big muscle. So usually it is obvious in the tongue, and it is a sign of denervation. Sensory abnormality also, it is indicating neuropathy. Fatigable weakness, it is characteristic feature of myasthenia gravis. Myotonia may be seen in few myopathies. And what do you mean by myotonia? It is characterized by delayed relaxation after prolonged contraction and squeezing. If you squeeze the hand and powerfully, and when you start to relax your hand and finger, and you'll see there is delayed relaxation, as is seen in this figure. What about the muscle pain or myalgia? This is not differential point between neuropathy and myopathy. Why? Because it is associated with many myopathic or neurogenic origin weakness. As here in this example, the acute dermatomyositis and acute polyneuropathy, which called the Guillain-Barré syndrome, they are characterized by myalgia. And here we have dermatomyositis is disease of muscle, while polyneuropathy is disease of nerve. Both of them got myalgia, so it is not a differential point. Another example, we have a muscular dystrophy, which is disease of muscle, and the spinal muscular atrophy, which is disease of the nerve. They are not associated with myalgia or pain. Also, we may see the pain or myalgia in many metabolic diseases of the muscle, and may be seen in ischemic myopathy as in dermatomyositis. Myalgia means or indicate acuity. It is not an indicative of the nature of the disease, whether it is a chronic or a progressive. And an example, we have a progressive chronic disease like a muscular dystrophy and the spinal muscular atrophy. They are not painful, there is no myalgia. But when acute stage of inflammatory myopathy and acute denervation of the muscle, often they do present with a muscular pain and tenderness to palpation. Regarding contracture of the muscle, may be present at birth or may develop later during the course of disease, and it also occur in both in myopathic and neurogenic disease, so it is not a differential point. We have another characteristic finding, there is undescending testis. This is occur because actually the testis normally pulled into scrotum from the anterior abdominal wall by pair of cords. The cord consists of a smooth and serrated muscle. It's called the gabernacula. And gabernacula are weakened in many congenital neuromuscular diseases like spinal muscular atrophy and myotonic muscular dystrophy and many congenital myopathies. So another feature here, we have the funnel-shaped thorax, usually seen because of the funnel shape as in this picture. This looks like funnel, the chest here, because of muscle weakness, intercostal muscle weakness, and the ribs are thin and radiolucent. And it is characteristic finding in infantile spinal muscular atrophy and in myotubular myopathy and in neonatal myotonic dystrophy. Other, we have to look for the birth weight. Usually they have low birth weight for gestational age. The common manifestation of the disease of neuromuscular function or disorder, they have generalized hypotonia and motor developmental delay. And it is a feature of infant and young children, and it may be an expression of a neurological disease or non-neurological, like endocrine and systemic metabolic disease, Down syndrome, malnutrition, chronic systemic illness. So it is a common manifestation, but it has many differential diagnoses. We have to ask about prenatal history. Usually they got decreased fetal movement through intrauterine life, and it is detected by serial ultrasound studies, and often found in patients who are symptomatic at birth. So they have decreased fetal movement and decreased fetal growth. And here, lastly, we have to ask about the developmental disorder. Usually they got slow onset and progressive disease. It started at certain age and it increased in severity with time. So how to differentiate between the upper motor neuron lesion and lower motor neuron lesion, neuromuscular junction, and myopathy? Whether it is actually is it a peripheral problem or it is central problem. So we have to differentiate. Here, atrophy is found in the lower motor neuron lesion and it is absent in upper neuron lesion and is mild in both injunctional and myopathic disease. Fasciculation is present here in the lower motor neuron lesion, but it is absent in the others. Tone, all of these, and it is flaccid and it is normal or reduced in myopathy, while it is flaccid in lower motor neuron and injunctional disease, and it is spastic in the upper. Weakness, usually it is pyramidal type in upper motor neuron, and it is distal, segmental in the lower motor neuron. It is variable in junctional type, and it is proximal, and this is the most important part here, as it is proximal in myopathy, distal in neuropathy, and variable in the junctional type. Reflexes, usually there is hyperreflexia in upper motor neuron lesion, there is areflexia or hyporeflexia in lower motor neuron lesion, and it is normal or hyporeflexia in both in the junctional and the myopathic type. Plantaris, which means the Babinski is upgoing in the upper motor neuron lesion, it is downgoing and or absent in lower motor neuron lesion, and it is downgoing, absent in junctional and also in myopathy. Laboratory finding, we have to check the serum enzymes. Usually it is increased, and we will check creatinine kinase, elevated in certain diseases like Duchenne muscular dystrophy. And we have to look for the molecular genetic markers, because in hereditary types, myopathy and neuropathy, the markers is evident. And we have the nerve conduction velocity. We check the motor and sensory nerve function. And in neuropathy, various type is detected, and there is decrease in the conduction velocity. EMG also is important to detect certain myopathies, and imaging of the muscle using ultrasonography, CT scan, and MRI also used in many neuromuscular disease. The MRI is important, very important, for inflammatory myopathy, and it is a study of choice to image spinal cord or nerve root. And also the muscle biopsy is important for the diagnostic, but most important and the specific diagnostic study for most of the neuromuscular disease. Also, we depend on the sural nerve biopsy, sometimes depending on this nerve, and also ECG, because cardiac evaluation is important, as is in some muscular dystrophy the heart is involved, and in some inflammatory and metabolic myopathy also the heart involved in form of conduction defect or cardiomyopathy, dilated cardiomyopathy. Serial pulmonary function also should be performed in muscular dystrophy, as it is a progressive disease. So we'll talk now about muscular dystrophy. They are a group of genetic myopathy, and there is a progressive weakness due to degeneration of the muscle, and usually involve the proximal muscle, and it may involve the cardiac and the smooth muscle. They have similar EMG finding and similar pathological finding. There are different varieties of the muscular dystrophy. All of them, they have elevated creatinine kinase. We have Duchenne muscular dystrophy and Becker muscular dystrophy, myotonic dystrophy, facioscapulohumeral dystrophy, limb-girdle muscular dystrophy. We will discuss now Duchenne muscular dystrophy. So it is common or not? Yes, it is the most common hereditary neuromuscular disease. Okay, hereditary, it is an X-linked recessive trait. The incidence is 1 per 3,600 live-born boys. They characterized by progressive weakness, intellectual impairment, hypertrophy of the calf muscle, and there is a proliferation of the connective tissue in the muscle. Sometimes, as we said, mostly it is inherited as X-linked recessive trait, but sometimes sporadic cases occur in 30%. So what's the pathogenesis? There is defect gene on the chromosome, on the X chromosome, and that defective gene results in failure of the body to produce a protein which is called the dystrophin. Dystrophin is a functional protein, protect the muscle from damage during contraction. And without dystrophin, the muscle fiber wastes away and replaced by scar and fatty tissue. So female here in this disease, they carry the genetic defect, but they are not affected. And they carry 50% of the responsibility of the offspring to have the disease to their sons. So clinical manifestation, usually the infant boy affected, they are rarely symptomatic at birth or early infancy. Sometimes they are mildly hypotonic. The symptoms appear at 3rd year of age with frequent fall. There is waddling gait, lumbar lordosis, difficulty climbing stairs, and difficulty arising from floor, as we call it the Gower sign. They clamp on their limbs when they start to raising from the floor. And children confined to wheelchair by 13 years. If they can move and ambulate, they prevent scoliosis. But when they are confined to wheelchair, scoliosis appear earlier. The function of the distal muscle is preserved. Respiratory involvement also is affected, and here the respiratory muscle affected, there is weak and defective cough, and they got repeated chest infection. Pharyngeal weakness also is an evident. There is recurrent aspiration, nasal, voice quality. As we said, the scoliosis is common. There is enlargement of the calf. We call it the pseudohypertrophy. There is wasting of the thigh muscle, which is a classical feature. Cardiomyopathy occur in 50 to 80%. There is tachycardia, myocardial failure, and intellectual impairment occur in all patients. This is a characteristic feature of Duchenne muscular dystrophy. Death occur usually about 18 to 20 years of age. And the causes of death here is important because of respiratory failure in sleep, intractable heart failure, pneumonia, and occasionally aspiration and airway. So they need a machine to evacuate the secretion overnight. Here, these are the characteristic findings. They got pain and stiffness in muscle, difficult running, jumping, difficult sitting, difficulty and standing, delayed development, waddling gait, and frequent falls. In Becker muscular dystrophy is another variety. It is less intense than the Duchenne muscular dystrophy, and there is a progressive muscle weakness, but it starts late, from any time from childhood into adolescent. So it occurs later onset, while in Duchenne muscular dystrophy started at the 3rd year. Here it is maybe in childhood or adolescent, and assisted ambulation. They can move, they can ambulate, and even after 15 years of age, they can survive to adult life, and learning disability are less frequent. So laboratory finding here, serum creatinine kinase level is increased in Duchenne muscular dystrophy even in the pre-symptomatic stage, even at birth. Cardiac assessment by echo is mandatory for evaluation of cardiomyopathy or cardiomegaly. ECG is important for conduction defect, and radiography of the chest also important to detect the heart and the chest as well. EMG show characteristic myopathic features. The diagnosis depend on the PCR polymerase chain reaction for detection of dystrophin gene. And here we have the creatinine kinase is increased consistently If the blood polymerase chain reaction is diagnostic, muscle biopsy is not needed. But if the PCR is normal and the clinical suspicion is high, we need to have muscle biopsy for a dystrophin immunocytochemistry analysis. So what's the treatment? There is neither medical cure and nor method of stopping the progression. But a new drug used here, Vondi's 53. Vondi's 53 promising, although still under trial, to improve life and decrease the progression of the disease. What are the complications? The complications are cardiac complication, pulmonary complication, there is a scoliosis, and maybe nutritional complication. So we have to treat the complication to improve the quality of life, and we have to improve the nutritional state. Physiotherapy may delay, but always not to prevent contracture. And sometimes we use steroid may decelerate myofibril necrosis and improve strength initially. So we have another disease, we call it disorder of the motor neuron. Here it is a spinal muscular atrophy. This is a degenerative disease of the motor neurons that begin in the fetal life. Usually it starts early, it is a progressive, and other types, there are different varieties, either a neonatal type or an infantile type or maybe juvenile type. It is the second most common neuromuscular disease after the dystrophic diseases. Also, it is a spinal muscular atrophy is an autosomal recessive disease. The incidence is 10 to 15 per 100,000 live birth. Usually there is muscle atrophy and weakness, and the cause here is due to deletion or mutation of SMN1 gene, which reduces the intracellular survival of motor neuron protein level, and this causes the atrophy. As we said, it is an autosomal recessive, so the parents are both carrier, and we have here affected 25% are affected and 50% are carrier, and healthy only 25% of their offsprings. So the classification, we have severe type as it's named Werding-Hoffman. It is 25% of cases. We call it the SMA type 1. Type 2 is a late infantile type, which is less progressive in nature, and the third one is a chronic or juvenile type, and we call the SMA type 3. It is also equals to 25% of cases. And this classification depending on the clinical picture, on the age of onset, severity, and the clinical course. This is a Werding-Hoffman, this is normal baby, and this is a baby with Werding-Hoffman. As you see here, there is, as you see, what you see here, the chest is funnel chest, there is weakness, the position is abnormal, and thin-built muscles. The clinical manifestation, as we said, it is autosomal recessive. Here there is severe hypotonia, there is generalized weakness, thin muscle mass, and the tender reflex are absent. There is respiratory distress because of involvement of the respiratory muscle of the intercostal, subcostal muscles, and even the sternocleidomastoid here is affected, and there is congenital contracture. More than 2/3 of patients die by 2 years. While SMA type 2, they have a slower progression and may survive into school age. In type 3, it is the mildest form. The patient appear normal in infancy, but the weakness starts, as we said, it is proximal in distribution and involving the shoulder girdle muscles. Fasciculation is a specific finding due to denervation of the muscle, and it is observed better in the tongue. What are the laboratory findings here? The creatinine kinase is normal or mildly is elevated, and the result of motor nerve conduction are normal. Diagnosis here is the most definitive diagnosis is molecular genetic marker for detection of the abnormal gene. So the enzyme study and the nerve conduction velocity is normal, but diagnosis depend on the molecular genetic for identification of the abnormal gene. What's the treatment? For SMA type 1, there is no medical treatment. No treatment able to delay the progression or to improve life. But new medication trial, as we know, we call it The nusinersen. The nusinersen, marketed as Spinraza, is a medication used to treat spinal muscular atrophy, and in December 2016 it started to use this medication. It became the first approved drug used in treating this disorder, and it was costly. Earlier it cost $750,000 in the first year, and then annually after that in the United States as in of 2019 the cost was $375,000, and they should have the medication intrathecally to decrease the progression of the disease and to improve lifespan. Thank you very much.